Afternoon. I also want to express just a ton of gratitude. This is a really incredible conference, and I've just had a great time the past couple days. I'm humbled, I guess, because, okay. I'm humbled because I was invited to speak by, as the story goes, by two people who had never met me, talking and deciding that I would be a good speaker for this conference. And what my bio says about me is part of the truth about me, but it's really not what qualifies me to stand before you today. And I'm really here based on the lessons I've learned through failure, and those lessons are uniquely mine, but I think they're also common enough to be relatable. I've spent the last several years of my life trying to understand how to teach pain science into the patient narrative, into each patient's story. And I really do take quite a bit of pride in being able to walk this tightrope, particularly relative to my other physician colleagues, between validating the patient experience and also being able to speak to the truth of what pain science means and what those implications are, but doing that in a way that reassures and empowers and gives hope. And that's what we're all here trying to learn how to do, right? So the interesting thing is, I don't always do that very well. I don't know if any of you can relate to that, but sometimes I get it wrong, like really wrong. And my analogies fall flat, or the person doesn't feel heard, or my sequence of delivery is not what they're ready to hear. And then even more frequently, I'll encounter colleagues who aren't open to hearing about pain science because they already understand pain, or they're just not open to hearing from me about how to do a better job with something they already have a file for. Does that sound familiar to anybody? Yeah, it's pretty common. So before we go any further, I want to revisit the invitation and say that what I first experienced was a combination that was probably 80% anxiety and 20% excitement, and that made, and it was really because I felt kind of more of an imposter. Like, what do I have to do? What credibility do I have to give people motivation to go back to our jobs tomorrow, inspiring people, and not feeling overwhelmed with all of this stuff that we've just been fed over the past couple days. Rajam's emails to me said, I'd like you to be kind of a motivational speaker, and I was sitting there thinking during our last talk that we just had that, but I think. The anxiety and the imposter syndrome for me is it really arises out of the fact that I don't conceive of myself as a motivational speaker. And I think what motivated me to accept the invitation and to talk about, all right, well, what do I do when I get pushback, is that I feel like I am qualified to talk about integrity. And I don't just mean that in the moral sense. Integrity for me, from the Latin root for wholeness, means being the same on the inside and on the outside. And I think what that means about teaching pain science to folks, or better said, what I do for a living is interact with people's threat detection systems, right? And I think that's what we all do. And if I'm not capable of recognizing my own threat detection system, then I don't really have any business helping people. It was kind of like the question that was asked about a mindfulness practice, that I don't really have the integrity. I don't have the same on the inside, on the outside, in helping people choose a different response to their threat detection system. And so what I'm going to try to do this afternoon, thanks for the daylight savings time shift, is take off my mask a little bit. Because I think, mask is fundamentally about what we do. Putting on a mask is one of the protective outputs of our threat detection system. So I'd like to contextualize some of these themes based on my journey in recovery, and specifically recognizing what part of me is an addict and what part of me is codependent. One of the earliest shifts happened as I learned to see and own in myself what bothers me most about others. And I think that's something that's really difficult to do, particularly in the moment. But this first hit me when I was journaling about how much resentment I had toward obese people. That's this poor guy who's, and you can download his picture on the internet. My resentment was because they don't, I was feeling like they don't take care of themselves, they make my job so much harder. Until I realized, literally as I'm journaling, that as somebody who can eat 24 chocolate chip cookies in a sitting, they don't have anything on my lack of impulse control. I just happen to have my gluttony offset by another character defect that is, I have just enough vanity that I go to the gym every once in a while, but that doesn't give me moral superiority. And then later, I remember reflecting on I was observing a link between codependency and fibromyalgia, and I thought the reference yesterday to kind of the Spanish term for it being a needy woman's disease was really impactful. And what I perceived as this sense of passivity and kind of a victim mindset would send me running. I didn't feel like I had stuff to offer to chronic widespread pain. I couldn't give that person a different childhood. I couldn't take them out of their family roles. But then I was confronted by how codependency drives so much of what takes all of us into healthcare. I remember it was during my internship, and it was a lecture from a psychiatrist, and I had to reconcile that what bothered me so much was the fact that I shared all those same traits, and I felt just as powerless over my need to be needed and my need to rescue people and to caretake. And that I had just as many such difficulty setting boundaries around self-care and self-compassion. And then most recently, I would say, how about fear? And what is it about anxious people that bothers me so much? If you'd asked me 5 or 10 years ago, I would have told you that I didn't really identify with fear or anxiety. In fact, I remember telling that to an addiction counselor 20 years ago, that I don't understand fear. But one of the things that I've been ashamed to admit is just how much of my life is run by fear. I'm afraid of what people think of me, which is why I have a dry mouth right now. I'm afraid of financial insecurity. I'm afraid of how my kids will turn out. I'm afraid of the future of healthcare. I'm afraid of being a failure to my patients. I'm afraid of the future of the country, who isn't, and the planet, and the list goes on. And people tell me that I hide it pretty well, unless they live with me. or work closely with me. Because those that do what I do, they're regularly aware of how reflexive it is for me to try to control my environment in response to perceived threat. With anger, with withdrawal, escaping, with just one more beer, preferably a great West Coast IPA, by taking on a huge project at home or at work, by trying to start a company on the side, by binge watching Netflix, by training for some epic exercise adventure that'll give you this awesome t-shirt. And so looking through that lens, I'm now able to recognize a constant low level of anxiety that has driven all this achievement. And today I see all of it as protective output from the same threat detection system that produces pain. And I think that's key to identifying with those I'm trying to help. So taken a different way, what bothers me most about others? Me. So before we move on, I'd invite you to reflect on an area of pushback in your life, personally or professionally. It could be an area where you feel something or someone pushing back against you, or where your own self is doing the pushing. Maybe you're the one resisting change. Perhaps you're having a strong reaction to someone in your life who is. Want to just ponder that for a second? What comes to mind? So what do I do when I get pushback? It's as I learn not to avoid those fears, but lean into them and choose vulnerability and accepting my limitations, that I've learned better ways to respond to my own threat detection system. And the Serenity prayer is most known for its use in 12-step programs for addiction, but it's a key piece of wisdom that's applicable to other areas of recovery, common to the human condition. Trauma recovery, relationships and breakups, etc. And by applying those same principles to my practice as a pain physician, I'm better able to identify how I can bring my patients into the same space. So we're going to look at this as the architecture for the rest of the talk. Grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. So what are some things that I can't change in the context of pushback, in the context of trying to teach pain science into the patient narrative, in the context of trying to help people? I can't change that person's story from when they were born until when they meet me, right? I can't change the patient as I find them. I can't change how much effort they're willing to put in today, their readiness for change. I can't change their baseline health literacy. I can't change their social environment or their economic status. I can't change the extent of sensitization that is already a product of their story. I can't change the speed at which they heal, whether we're talking about their tissues or the way their brain changes. I can't change how threatened they are by being in my office, by where they were coming from when they walked in the door, or how high they perceive the stakes to be about this visit. And then if I take it to the colleague side of things, which I think is another realm for pushback, right? I can't change the degree to which my colleague's mindset is fixed. I can't change the degree to which pain science threatens their livelihood. I'm talking about, talking with my neurosurgical colleagues. And so as you think about your area of pushback that came to mind a minute ago, what are some things that are out of your control with respect to that? What are some variables that you can't change? And what I'd invite you to do is just mentally set them aside. Don't absorb them. They're not yours, right? That's something that you do have a choice over, is whether you can accept The fact that you don't, those aren't under your control. You can't change those. And I think that's what brings about the sense of serenity. Grant me the serenity to accept the things I cannot change. So, but then it goes on, and it says, courage to change the things I can. So, this is my brainstormed list of 10 acts of courage that, things that I can change. So one is self-awareness. And this could be a course in and of itself. But, one of the things that comes to my mind is when I've, few things are scarier for me than being responsible and feeling incapable at the same time. And especially when the stakes are high. So giving this lecture brings up some anxiety for me, but running a code brings up a ton more. I don't work in what I call adrenaline medicine, even though I love adrenaline. I don't like it at work. And when you learn to run a code in training, it's classically one of those circumstances where life and death outcomes meets one's insecurity head on. And so you're taught, when you're called to a code, to check your own pulse first. And why would that be? Because trauma research shows that when you're in fight or flight mode, your frontal cortex, your ability to make executive decision making is compromised. And so your first response is to calm yourself down so that you're not a liability to the situation. And I think that bears thinking as we think about how to move through our clinic day as well. So what triggers my threat detection system? What are the settings on my threat detection system that I carry into the treatment room? Right then. How was my morning? How's my relationship with my significant other today? Am I hungry, angry, lonely, or tired? What leads me to post hastily on social media in a way that I regret? These triggers are all mine to own. I'm responsible for my buttons. In fact, at the end of the day, pushback is my perception. And it's my perception to own. We have a tendency to think that pushback is about the circumstances where we find ourselves, or it's about the other person. It's my perception. So doing some work exploring our own triggers, their relationships to our trauma history, what we're sensitized to, things that are standard in the training of mental health practitioners should be brought to bear on learning to, and I love the Viktor Frankl quote, to create space between stimulus and response. I've heard that also operationally, or used to operationally define emotional intelligence. It's the ability to create that space between stimulus and response. My response to my own fear. And I think the term that was used yesterday was the behavioral flexibility exposure. It brings the same process to mind. Well, this is what we're trying to do with our patients. It equally applies to us. Anybody know this triangle? Right? So this was also written on a napkin in a Pizza Hut during my internship by the same guy that gave me that lecture about codependency in healthcare. And Cartman's drama triangle goes back 40 years in terms of research. But the idea is that if we're not secure in our identity, we're going to adopt one of these roles. And it'll change in different situations in our life. But I would say that for most of us in the helping professions, we identify most with the rescuer. And what's interesting about this triangle is for me to be a rescuer, I can't be a rescuer by myself. I need to assign the other two roles. So I have to define someone else as the victim, and I have to define someone or something else as the perpetrator. And when we talked about, I thought Joe's comment about, stealing power from the patient or disempowering the patient, what do you think? What do you think we do to someone when they come in and we say to them in our own minds, you are the victim and I'm going to be the rescuer? We're going to play those roles. No wonder they have trouble moving off that part of the triangle under our care, to the extent that we live up, that we need to feel good about ourselves and our need to be needed. So, signs that I might be stuck there is when I feel like I'm working harder than the patient, and other lessons from codependency. My natural tendency is that I like to be the one doing the helping. I don't want to be someone who needs help. Heaven forbid I end up like my patients, right? It goes back to my fear and my sense of vulnerability. So getting really clear internally about what needs I'm trying to meet in myself on this triangle is fundamental to helping my client, my patient, get out of theirs, off their triangle. As an example, my personal tendency to absorb the patient's hope that I fix them used to be how hard I would try with manual treatment. And then it became how good I was at interventional treatment, procedures. And I'm still vulnerable to this kind of thinking error, although now I'm more likely to try to fix them with a fire hose of pain science. But that's still me up in the corner as the rescuer. And so this motivation is all about me, and it'll get in the way of helping. And the other thing is that struck me is you can't do motivational interviewing as the rescuer, right? So change is hard. I love the exercise that we just did, and taking it all the way back to us having to set goals for ourselves. What I was going to invite you to do is reflect on some things that you've wanted to change about yourself over the past couple of years but haven't. And then among that list, which are the things that actually made it onto the list of times that things that you've actually tried to change, and which ones didn't, and do you know why? Understanding those things in ourselves and being able to go through that process of actually setting goals and trying to adhere, to smart, measurable, attainable, realistic, and timely goals will help us empathize with how hard that is. One of the things in motivational interviewing that has been the most difficult for me is to identify with the ambivalence that the patient experiences. There's a lot of talk about we just need to shut up and listen. We need to let the patient tell their story. If I peel back the layers, for me, what makes that most difficult is that that feels like a Jedi skill, and it's one that I'm sure my wife and my kids wish I were better at. Reflective listening, not trying to jump in and change, and because my natural tendency is to be prescriptive, right? That's why I became a physician, so that I could live out my days up in the rescuer corner where people would come into me and I would bestow great wisdom on them, and they would they would be very grateful and go out and carry out my instructions. It's not how my practice looks. I don't know if it's how your practice looks. But I also see this as a measure of whether I'm out of the drama triangle. And so I've had to learn to stop prescribing, even from an advice perspective, long enough to ask and listen. So I alluded to this earlier. See the patient's threat detection system, and one of the things that has been helpful, I've really enjoyed this question recently as an opener with both patients and colleagues, but how does your brain know what's dangerous? Right? I mean, most people don't pause to think about that, but it's a great entree into, well, we're not born knowing what's dangerous, so it must be through experience. We must learn it, and then that helps to fill out a context where we can talk about the fact that our brains are the product of our story, and that's true no more so than with our threat detection system. So I think the best thing I can do when I experience pushback, whether from colleagues or patients, is to recognize that I've triggered their threat detection system. And then that in turn has triggered mine, right? Because I'm identifying it as pushback. So there we are, both being triggered. And what I need to do is find a way to identify with and validate that instead of trying to squelch it or overpower their protective response. And I think somewhere in there is the way to move toward that place of shared vulnerability, of that third space. I'm convinced that good clinicians have learned, although they may not articulate it as such, that fundamentally they're addressing the threat detection system of their patient. And I think great ones know how to respond to that protection with the therapeutic balance of empathy and truth. So Brené Brown's TED Talk on the power of vulnerability undid me when I watched that. And with 33 million views, and I think it's in the top 5 TED Talks of all time, I'm sure I'm not the only one. But what does this have to do with helping people with pain? Well, everything. We can't teach others with authenticity if we don't learn to respond differently to our own protective outputs. And I alluded to this at the beginning. We can't take anyone anywhere we haven't been, and that includes learning to develop resilience, which could be defined as choosing a non-default response to our threat detection system. Playing in the mud used to be exhilarating, but now we're professionals, so it feels much riskier to sit beside someone in the muddiness of their life. And I loved what Mark said this morning when he talked about his family swarming around him, and he said, what would have been most helpful, what's most helpful in suffering is just sit there with me in the mud. Don't try to change me, don't try to fix me. So here are the first 5. Self-awareness, get off Cartman's triangle, empathize with ambivalence, see their threat detection system, and choose vulnerability. What if we don't know where to start with pain science? One option is just find one thing for that patient that day. Start where you are. So if pain, as Lorimer and David have recently defined it, as a feeling created by the brain when the credible evidence of danger to the body outweighs the credible evidence of safety, then find one thing, one small way to change the perceived threat value of what the other person is experiencing, of what pain means and what it doesn't, of what's happening inside the body and what isn't. Seventh one, and you'll start to see these are going to start to overlap considerably, but practicing self-compassion as a means of integrity, and again, not the sense of moral integrity, but the inside matching the outside. And I'm going to say, there's a hypocrite alert here. I'm currently enrolled in a mindfulness-based stress reduction class for the first time. I'm in week 3 or 4, and I'm not doing my homework. It's excruciating. It's just very difficult for me. I've so trained myself to ignore me that it's not until I'm actually in the bathroom that I'll recognize that I've been running around like a crazy person for hours, totally unaware of my full bladder. Can anybody else relate to that? I went to work all this week when I should have been in bed with the false belief that doctors don't call in sick and no one else is going to see my patients if I stay home. So do as I say, not as I do, it should be the other name for this. I believe that it's important that we model what it means to value caring enough about ourselves to change. But like I said, I have a really hard time with this, and you might be able to tell from my voice, but I texted a friend earlier this week, and she asked, "How are you feeling?" And I said, "I think I gave myself psychosomatic pneumonia." And so I finally did go to the doctor on Thursday to get some placebo antibiotics for my psychosomatic pneumonia. So allowing the patient to grow resilience by encouraging. Brene Brown talks about that as a verb, as a practice, and I've learned so much from the mouths of our patient panel and the voices of patients over the years. But just thinking about whose values are we treating, and if we're inserting ourselves into the rescuer role, this circles back. One of the things that has been the most helpful for me in thinking about freeing myself from that codependent role is that people don't learn if they're not allowed to struggle. They don't get stronger if they're not allowed to fail. And I see that in my life as a parent. The difficulty between allowing someone you love to suffer, but then also the fear that if I don't allow them to suffer, then they're going to end up, being, fragile and not having enough grit and resilience to be successful as adult humans. I was once told that when folks from the West express spiritual petition, the prayer is usually a variation of, "God, take this burden from my back." Whereas, generally speaking, Eastern cultures have a greater tendency to pray, "Please strengthen my back." And then similarly, the Norwegians have a saying, "There's no bad weather, just bad clothing." Which is another spin on resilience, right? And so when I'm working on taking away suffering, and I'm working harder than the patient, sometimes I wonder if I'd be more helpful being with and helping others bear their suffering rather than trying to remove it. And then that also ties into number 9, remembering our values. So the thing that I've been emotionally impacted by is the tremendous strength of my patients in the face of adversity. And many days I have to dig deep to endure another story of suffering. And that's mostly about me absorbing stuff I can't change. And I know, knowing that my patient needs to know they're heard and understood and believed, and to know that I care before they care what I know. And I need to face my feelings of inadequacy to meet their understandable hopes and sometimes unrealistic expectations born from their desperation for aid. It requires a tremendous emotional investment, but it gives back because it allows me to enter this sacred place in their lives where I see their experience and strength and hope as they're able to thrive. And that's what makes it worth it, isn't it? I mean, that's why we do what we do. And so the ability to kind of return to our compass heading about where we find value in our work, I think is one key to resilience. And then practice belonging. Ask for help, stay connected. You're not alone, and neither are those who are suffering. Find and stay connected to your tribe. As evidenced around us this weekend, there's a growing international community of folks who are captivated with the same pain science and see how transformative it can be for people in pain and in healthcare in general. When we zoom out of our own self-centeredness, out past our own neighborhood, our political bias, and begin to see what our fellow humans are dealing with all around the world, it's really sobering. And especially in an era of increasing protectionism and isolation, it's empowering to see ourselves as part of the global health solution. And this is ultimately about belonging. As Lorimer said to Joe, loving and being loved. So they're the second 5. Find one thing, self-compassion, allow your patients to grow resilient and to practice courage. Remember why this is important to you, and practice belonging. So where do we go from tonight? I would submit for your consideration that we're not just talking about pain. As Lorimer puts it, pain is just one of the protective outputs of this threat detection system. In fact, the threshold for accessing the healthcare system electively, as opposed to when someone else calls the ambulance for you, when you seek care, when your patient seeks care, that threshold is not really driven by the severity of illness. It's driven by this same threat detection system. On one side of this threshold, we can handle it. We understand what this symptom means. We think it's safe for us to manage this on our own. Millions of people went to the emergency department last night with belly pain that you would have taken a Tums for, or stretched, or drank warm water, and gone back to bed. But with a nod to Dr. Akparian, I think what this represents is prior sensitization of the mesolimbic system that he was highlighting. In other words, this isn't just about pain. This is about how we change healthcare. And even more than that, threat detection and protection is a lens that starts to explain a whole range of human behavior in almost every context imaginable, from parenting to politics, from work comp to our work colleagues, and from other drivers on the road to the drivers of healthcare. So when you're feeling overwhelmed that there's too much to take on, I'd offer that this is such a big and pervasive issue that fixing it isn't your responsibility. You're not the rescuer, but learning to recognize and respond to your threat detection system is ultimately how we make a better world together. So we've got a couple minutes left, and as we prepare to close this conference, I thought it would be helpful to pause for some personal reflection. I'm going to give you a few minutes to allow your mind to remember one or two things that most impacted you this weekend. Especially if you recognize it stirring in your threat detection system. Maybe it's an intellectual challenge about your command of the science. Maybe it's how this applies to one particular patient or client. Maybe it's a connection to things outside the professional, to relationships that will be with you longer than your clients. Maybe it's the area of pushback that you thought of earlier. Brené Brown defines courage from the French word for heart as wholeheartedness, showing up, showing yourself, coming out of hiding, daring, or in the words of this quote, speaking one's mind by telling all one's heart. I've tried to do that tonight, and one of my fears is that I don't have a lot more to say, and so I'm afraid that somebody's going to ask me a question I don't have the answer to. I am happy to answer questions, but I think what I've been most impacted by at the end of conferences is when I hear from lots of other people about what impacted them most and what they're taking home, and I think that's a really nice way to close. And so the next 5 minutes and 29 seconds are mine, and then there's Q&A after that. But what I'd like to do is open up the floor at this point and allow those among you who are courageous to share maybe the 15 to 30 second version of something that impacted you, something that you're willing to be vulnerable about maybe. Do you have any takers?
I just want to thank you very much for this. It's the last conversation of the whole week, and I'm just grateful that you came out and put yourself out there like that. For the last it's been a little more than a year. I've been the patient for the first time and have not been doing my practice, and haven't really known exactly where I'm going to go with working and career and all these things. And so I really appreciate this conversation. Thank you.
What's your name?
Maggie.
Maggie, thanks.
Chris, over here. This was one of the most meaningful talks of the day. This has been a rather emotional day for me, and I've been opened and triggered a bit. My wife is in a 12-step program, and this seems right along the line with what she's doing. I want to thank you for your vulnerability and courage. This has been very meaningful to me. Thank you.
Thanks.
Kind of what I want to share is, from a brand new practitioner. I'm a new grad PT, graduated last May. And so for a lot of reasons, I've been interested in pain science and pain education and learning more about it and things like this. But, we sometimes mention imposter syndrome. I mean, early on, I know that one of the other talks, someone had said that, take our patients home and stuff like that, and I constantly worry that I'm not doing, what I can or should be doing. And so I'm, trying to delve into this as much as I can and online and everything like this because, I want to help folks. Where I work, it's our mission is incredible in that, we see patients, we don't charge or anything like that. And I mean, it's just a very patient, practitioner interaction that's pretty awesome, and I'm very grateful to have that. But again, it's just one of those things that I'm constantly worrying about that. And I know that as I, grow and become more, confident, I guess, I think that hopefully will subside because it certainly takes a toll sometimes whenever I get home. My wife and kids, and my wife can certainly see that, and she feels it right along with me. So that's just one thing that I wanted to kind of share from a new grad perspective. I know there's a lot of folks there's a lot of experience in this room, and I'm very intimidated by that. And so, that's just something I think from a perspective of someone who's brand new at this. So.
Thanks. We've all been there, haven't we?
We have a comment over here in the middle, and while the microphone's traveling over, I really appreciated your talk as well. Aside from my own practice, I teach continuing education classes, and one comment that I keep getting back year after year is a lot of people really appreciate the fact that I share stories of my failures, and that I give them permission to be wrong, and that it's okay to doubt yourself, and that it's okay to change course rather than just plowing through with what you originally intended to do. And apparently that message isn't being heard as much as it could be. But for myself, I was a chronic pain patient, and I didn't get help until I was working with practitioners that were willing to change course and give themselves permission to be wrong and rethink things. So it's great to hear it again.
Thanks.
Thank you so much. This one like really hit me in the chest. It was, as far as like self-awareness work goes, and it's something, I have no idea why that isn't the first thing, whatever somebody's discipline is, why that isn't the first work that's done in any program. Had I listened to this when I was first starting out, I can look back and see all the roller coaster of emotions that it could have saved me in a way. And as far as, what really got me, and something that I carried a lot of guilt about, was having judgments and opinions about, certain clients coming in and wondering, where's this, an example like bro-y Wall Street dudes. I just couldn't stand them. I couldn't figure out why. And there was this turning point that happened where one just started crying on my table, had a bad breakup, and all this stuff came up. And I was just like, whoa, it was a huge moment. And from then on, I learned to kind of, it's not like somebody's coming to me to do something to them, but rather like we're mirrors for each other. And when I started looking at things that way, my practice shifted a lot. It's a learning experience for both of us, and I'm fumbling around just as much as they are. And to see somebody, of course, with your experience, in a weird way, it's reassuring that other people are fumbling around.
Yeah, you're welcome.
But yeah, just thank you. It really got me. Thanks.
Yeah, thanks.
That was great. It's my first pain summit, and I've followed it for the last year, and this has been a great opportunity for me to meet a lot of the people that I've been kind of following and admiring through social media, and it was great to have my phone open up and have them all walk out of it, have a chance to meet, talk, have a drink, have some food. And a couple things you said, and when you put up with the triangle and talked about the rescuer, but also mentioned about not taking any time off, that you might have been the one with a 104 fever, but you were the one who was going to work and not staying in bed. And through all of this, what I've found, and I'm not sure if anyone else has had this same internal conversation about what makes it so that we're addicted to being the superhero. And that somehow our failure to step up and be the one that is there to rescue our patients or our clients is a statement of personal failure. And so that's something I've been struggling with, both as a clinician and as a parent. So it's giving me a lot more to think about in probably the next 360 some odd days until the next pain summit comes around. Thank you so much.
Thank you.
Hi. I've had so many aha moments this weekend, but I have one client in particular who lately has been kind of getting on my nerves, which doesn't happen to me very often. And just sometime during the course of the weekend and listening to people, I saw things from his point of view. And it just shifted how I felt. And I feel able to go back and see him and have some compassion that was lacking. And I just want to express my gratitude to everyone who's been here, the presenters and the people who are here, because there's such a sense of camaraderie. There's such an amazing gathering of people with experience and knowledge, and nobody is full of themselves. And people share so openly and without reservation. And I sent an email to a friend of mine who's in biomedical research, and I told him that, and he said, I can't remember the last time I was in a room with people who weren't full of themselves. And we're really fortunate. And I'm just grateful to every single one.
Thanks. Yeah, pain has a way of taking us to the end of ourselves when we're either as patients or people trying to help, doesn't it?
So I just wanted to thank you too. And I think that this is so important because, I'm always, beating the drum for patients to be heard and validated and believed. And clinicians need that too. You guys need that space and that permission to be able to share and be vulnerable and have those honest discussions that can be really hard. So I'm really grateful for you and a lot of the people who have presented here for allowing that to happen, because I think that's where all those meaningful discussions come from and where so much of the good and going back comes from too. So I just want to thank you for that.
Thanks, Joe.
Chris, we had a comment from an online participant. You have the mic? Okay.
Yeah. So it's very important to several people who are online right now that hugs are sent to the room. There have been requests for bear hugs for Chris, for hugs around the room, all sorts of hugs, and we wanted to make sure that that sentiment got expressed.
I mean, there's only one way to express that, right? Stand up. Hugs around the room. Stand up and hug your neighbor. Hey.
I'm an osteopathic.
Awesome. Kirksville. Oh yeah, nice. Hey. Oh, thanks. You want to kumbaya or what? I don't have any kind of agenda.
All right, one last comment in the back.
That did seem like a suitable place to wrap up, but thank you very much, Chris. That was very honest and beautiful. I guess I feel an aha moment for me right now is coming in thinking I was coming as a clinician and feeling more like a patient to a certain extent in a good way. The lovely lady who was so concerned with her 16-year-old going through chronic pain, is she still here? I had significant chronic pain when I was 13 years old, and the one thing that I look back on is how alone I really felt going through that whole process. And I feel like a lot of people have touched on the fact that you have to just sit there with certain people and not try to change too much. And so when your daughter looks back and knows that you were there, that's going to be the most meaningful thing for her, I think. So anyway, much love to everyone. Thank you very much.
Everyone, please join me in thanking Chris Caldwell.